Good morning, good afternoon, good evening from wherever you are joining me from today. My name is Margaret Gyapong, and I'll be taking you through Module 5 of our subject matter expert training on female genital schistosomiasis. Module 5 would focus on stigma, social inclusion, and community outreach for FGS awareness. I hope you've enjoyed the previous modules so far and you have learned a lot. At the end of this training, I'm hoping that you'll be able to describe what stigma and social inclusion is, be able to recognize the importance of stigma, and be able to demonstrate the skills to address stigma and discrimination in a non-clinical setting. I'm hoping also that you'll be able to explain how to communicate the causes of schistosomiasis and female genital schistosomiasis, their symptoms and complications of FGS, and referral for care in a non-clinical community setting. I hope also that you'll be able to explain how to communicate the prevention and control of schistosomiasis and FGS and interpret the mechanisms to engage community in FGS awareness. Much of what we'll be talking about will be from several publications, but our main resource for this particular module is this particular article which I authored with my colleagues. So, to the subject matter for this session, stigma and social inclusion. First of all, we'll look at social inclusion and equity, which basically are fundamental principles of social justice. In every society, there are principles of social inclusion and equity. Now, when we talk about social inclusion and equity, we want to ensure that individuals, groups, and communities are able to participate meaningfully in our communities and in society. Participate meaningfully and fully. Sometimes you find out that people are supposed to participate in activities, but due to one reason or another, they are not able to do so fully and in a meaningful way. So when we talk about social inclusion and equity, we want to ensure that everybody takes part in everything in a meaningful way, irrespective of their social class, their ability to do certain things, or even the fact that they have certain conditions that may make it difficult for them to be part of the ongoing process. Social inclusion and equity involves improving the ability, opportunity, and dignity of those disadvantaged based on their identity to be included in activities. By virtue of the way people are created, or the kinds of conditions they have, or the social economic environment in which they found themselves in, sometimes they are excluded from certain activities. But we think that it's important that they are included in everything. Now, I want to ask a couple of questions. In the communities that you serve, are there groups you think are left out or find it difficult to access information and services? Do you think there's an equity gap in these communities? For instance, do you think young mothers or girls out of school are left behind in certain activities? What can you do to improve social inclusion and equity? I hope that the definition that I presented is the same as you are thinking when we talk about social inclusion and equity. Reflect on the questions I've asked and let's look at how you can answer the questions I've posed. So now let's take stigma. What is stigma? If you look in the literature, stigma is a mark of disgrace or discrimination associated with a particular circumstance, quality, or person. Most often than not, it is a negative response to our differences. I talked about it earlier on. Our social status, our health conditions, even the way we look. And because of that, sometimes you are stigmatized. The stigma can be discreet or obvious. So sometimes you are stigmatized in a way that you may not recognize or others around may not recognize, but you are being stigmatized. For example, name calling. Because of a particular feature that you have or because of a particular look that you have, you may be called names, funny names, names that will make you uncomfortable. Or making someone sit somewhere else because of who they are. So there can be a community gathering, everybody is present at the gathering, but somebody is excluded or asked to sit at the back, maybe because of the way the person is dressed, or maybe because of the person's social status. We know in our society that sometimes when functions are held, the front seats are reserved for the most important people, and those who are not so important are left at the back. It is a form of stigma. When we do these things because someone has a health condition like FGS, we call it health-related stigma. Now, there are 3 types of stigma. The experienced stigma, where someone is treated differently because of a health condition. So for instance, you have elephantiasis of the leg. It becomes very big, it pours out pus, it has a bad smell, and so you lose your job because 1, you are not able to work, or 2, people become uncomfortable around you. Then there's anticipated stigma, where somebody is afraid that people will treat them differently because of their condition. So maybe you have big legs, or you have any health condition, think about it. And people are really not paying attention to you, but you think that people are paying attention to you and making derogatory remarks about you. And that is anticipated stigma. So you expect that people will stigmatize you because of your condition. And then there's the internalized stigma, where somebody holds a negative belief about a health condition, and if diagnosed with it, they apply the feelings to themselves. So you have types of stigma where people stigmatize you, where you are anticipating that people are going to stigmatize you, and where you are stigmatizing yourself, even when sometimes others are not stigmatizing you. And these 3 types affect people differently and in different ways. Now, when it comes to FGS, our subject matter, there are issues related to stigma. Once we have created the awareness and people know about it, there may be the fear of getting FGS or even infecting others. There are also issues around religion and our cultural values related to sex and marriage. And you may have heard already that some of our healthcare providers think that when you show the signs and symptoms of FGS is as a result of infidelity. And if you read the paper that I shared, the resource, you find out that there was a young girl in that paper who said she hadn't had sex before. She was showing signs of FGS, went to the hospital, and the nurses told her that she's a bad girl and she's been having sex. Last but not the least, if FGS is being talked about or labeled negatively in the community or the media, it can also lead to stigma. So it depends on the way it is presented. If we present it as a stigmatizing condition, then people will be stigmatized about it. So there's a need for us to be careful about the way we present FGS. Now, if people are stigmatized because of FGS, it affects them in various ways. It affects their mental health. People become psychologically distressed. In the culture from which I come, if you're a woman and you are experiencing the signs and symptoms of FGS, then you are stigmatized, especially where you cannot have children. A woman in a Ghanaian society who has been married and does not have children is stigmatized highly. So it affects them psychosocially, it affects them psychologically, it affects their mental well-being, and it becomes a problem to them. So let me ask you a few more questions. Having heard what I've talked about regarding stigma of FGS, what interventions can you put in place to reduce the stigma? What can you do to ensure that your interventions are inclusive and reduce stigma? And I'm expecting that you'll be able to discuss skills that can support you to reduce stigma, particularly when supporting women and girls affected by female genital schistosomiasis. So take a break, just think through the issues. People have these conditions, they are not overt, they do not show on the person's body, it's internal, but yet it affects them psychologically, it affects their whole genital or their reproductive organs. And for a woman to have her reproductive organs affected negatively, it creates a big problem for them. We are looking at putting interventions in place to reduce stigma. What can you do? What innovative approaches can you use? Now let's move on to the second part of this module, which is community outreach, and I've added engagements to it to increase FGS awareness. Community outreach normally provides services of specific expertise to a group of people who may not otherwise have access to those services. So for example, our healthcare providers have gone out to the community and are talking about FGS. The community may not know about it, and so the health workers are educating them about it. Most of the time, it's a one-way activity, and the community is told what to do. Then you have community engagement, which is kind of the flip side of community outreach, where you work with the community to achieve a sustainable outcome, and there's an equitable decision-making process when you talk about community engagement. Remember when I started, we talked about social inclusion and equity. So if we want to get the community involved, we have to engage them. There are certain times that we have to reach out to them because of the subject matter, but it's also important to engage them. And when we do this community engagement, we deepen our relationship and trust between ourselves and the community is involved in the process that we are talking about. So why do we need to do outreach and engagement? First of all, we get to know, or we get to learn from the community about their experiences with schistosomiasis. So if we reach out to them and make them feel a part of the process, they have confidence in us and are able to tell us what they know and their experiences. If we engage the community properly, we'll be able to understand their beliefs and myths about causes of schistosomiasis and be able to demystify them. I'm sure you've read some of the articles and you've seen some of the beliefs that people have. If you have blood in your urine, it's a sign of maturity. If you have blood in your urine as a woman, it is normal, or it happens when you have just completed your period, and so it's not seen as schistosomiasis. We also learn what people say about those infected with the condition, including women and girls. And to be able to reach women and girls with information on FGS prevention, treatment, and control, we really need to do this outreach and engage with them. And we are talking about equity, so we cannot leave the men and boys, because if they go urinate in the water or defecate, then it ends up affecting the women who go to the water sources to perform their activities. So we need to reach out and engage both men and women. Now, like I said earlier on, there are all kinds of myths about schistosomiasis and FGS. And I want to just highlight a few of them. You may know some from the context in which you come. I want to highlight some that we know of. Some people believe that it's a disease that affects children and adults, which is caused by, the ways by which schisto is caused or transmitted. It's a disease that affects children and adults and is caused by a parasitic worm that is found in freshwater bodies like rivers and ponds. It is due to poor hygiene and sanitation, such as urination and passing stool near or in freshwater bodies, and I talked about that earlier. And it's due to human activities that bring people into contact with contaminated water. Example, bathing, swimming, farming, and more recently we've discovered that even things like water baptism for Christians could be a risk factor for schistosomiasis and female genital schistosomiasis. Now, these are some of the ways by which schistosomiasis is not spread or caused. It is not, you cannot get schistosomiasis by walking on the ground where somebody has passed urine, or by urinating on a snail, the snails that live in the water, or by drinking contaminated water. You don't get it as a result of a taboo or a curse, or even sexual intercourse with an infected person. Let me state that it is not a sexually transmitted infection, and this is something that we need to stress when we are engaging people. It is also not a sign of maturity, because in some communities it is believed that when men have schistosomiasis, it is a sign of maturity. So what are some of the symptoms and complications? Vaginal discharge, bloody discharge, bleeding after intercourse or spotting, itching, pelvic pain. Girls may present with some of these symptoms, and some patients may also have bloody urine. And most of the time it's bloody urine that you use to detect schistosomiasis in a community. Now, for some of the complications, you could bleed during examination, and sometimes infertility in advanced cases, abortion or ectopic pregnancy, involuntary urination when you cough or laugh. You may have genital ulcers, tumors or swelling in the vulva, vagina, or cervix, and several other complications. And it's an increased risk of acquiring HIV and AIDS in girls and women. So for prevention and control, there's the need to treat those who have the disease with praziquantel. And mainly praziquantel is given during mass drug administration in schools and at the community level. There's a need for people to seek early treatment from our local health facilities in case of any signs and symptoms of schistosomiasis. It's important to practice proper hygiene by using toilets and pit latrines properly if they are available. Where they are not, the community should look at a way of ensuring that people dispose of their waste in the most hygienic and appropriate way. People should avoid urinating and defecating in open places and water bodies, and avoid bathing and swimming and washing in contaminated bodies. Sometimes it's not easy to know which bodies are contaminated, but just avoid going near those places. It can also be difficult, especially where there's no pipe-borne water in the communities. But I think the communities can find a way of making the water safe for people to use. It's advised sometimes that water should be heated, water from contaminated sources should be heated for a short while before bathing, and water can be stored in a facility for between 1 to 2 days before using it for bathing and washing, and also spraying stagnant waters and bodies with chemicals so that the snails can be gotten rid of. So, like I said, the recommended treatment for schisto-FGS is praziquantel during MDA, 40 milligrams per kilogram body weight. There will be guidance from local public health officers about the use of a dose pole. So sometimes, because the community workers cannot properly weigh people, or there are no scales in the communities. It is the pole, the dose pole, that is used. So you get the height of the person and give a number of tablets according to height. This treatment, so taking 40 milligrams per kilogram body weight of praziquantel, kills the adult worms and prevents the development of new lesions. And treatment can improve some FGS symptoms. Praziquantel can also be combined with other deworming drugs such as albendazole as part of general deworming programs. So how do we engage the community in FGS awareness? You can have our health extension workers who go out, provide counseling, and refer suspected cases to the local clinic for treatment. Of course, it means that in that particular facility, the health workers should really know what FGS is to be able to handle a person when they arrive at the health facility. The health workers can also deliver health education talks, talk to people about avoidance of contact with freshwater sources. Sometimes they can also work in collaboration with other ministries, departments, and agencies who work in the area and whose responsibility is dealing with issues to do with water. And then they deliver treatment and provide information on where to access praziquantel, and also counsel women and girls on FGS and their chronic complications. Now, how to engage the community in FGS awareness? We have the school health programs and also at the community. So it can be done through health education in the schools, where the school health program engages with the ministries of health to be able to encourage them to take their medication during mass drug administration. And at the community level, engaging with community groups and teachers and other extension workers in ensuring that the information is passed round. Thank you very much for your attention. I hope you have enjoyed the course, and I look forward to engaging you when it is time for question and answer, and I wish you all the best in the continuation as you go through the rest of the modules. Thank you and have a good day.